Welcome to Roadmap to Residency. Today we are diving into hypertension management for your medical licensing exams Step 2. This is one of the highest yield topics you will encounter on board exams, and we are going to focus specifically on recognizing question patterns and applying test-taking strategies. By the end of this video, you will be able to spot the classic buzzwords and pick the right answer every time. Let us get started. Here is what we are covering today. First, you will learn to recognize the classic question stem patterns that distinguish primary from secondary hypertension. This is crucial because board exams love to test your ability to identify red flags. Second, we will master the critical differences between hypertensive emergency and urgency. This distinction determines whether your patient needs intravenous medications in the intensive care unit or can go home with oral therapy. Third, you will learn to apply medication selection algorithms to common vignette scenarios involving comorbidities. Remember, this video focuses on test-taking strategy. For the complete pathophysiology, make sure to review your board prep resources like UWorld, First Aid, and AMBOSS. Let us start with the fundamental framework. When you see a hypertension question, your first job is to determine if it is primary or secondary. Primary hypertension, also called essential hypertension, is by far the most common. Look for gradual onset in a patient over 40 with family history, obesity, or a sedentary lifestyle. This accounts for about 90% of cases. On the other side, secondary hypertension has specific red flags you need to memorize. Think secondary when you see young age under 30, abrupt onset, resistant to treatment, or specific clinical features. These features include hyperkalemia, abdominal brute, or episodic symptoms. When you spot these buzzwords, immediately think renovascular disease, primary aldosteronism, or pheochromocytoma. Let us look at these associations more closely. These buzzword associations are absolutely essential. Let us go through each one. For primary aldosteronism, remember this pattern. Resistant hypertension plus hypokalemia plus metabolic alkalosis equals aldosterone excess. The screening test is an aldosterone to renin ratio. For renovascular disease, the patient profile matters. A young female suggests fibromuscular dysplasia, while an older patient with atherosclerosis suggests renal artery stenosis. Look for an abdominal bruit or rising creatinine after starting an ACE inhibitor. These are classic board question setups. For pheochromocytoma, remember the episodic triad. Headaches plus palpitations plus diaphoresis. This equals catecholamine excess. Order 24-hour urine metanephrines. Now let us apply these patterns to a practice question. Here is our first practice question. A 28-year-old woman presents for routine evaluation. Blood pressure is 170/100 on multiple readings. She has no family history of hypertension and takes no medications. Physical exam reveals an abdominal brute. Labs show a creatinine of 1.0. What is the most likely diagnosis? Take a moment to think about the red flags here before we break this down. Let us break down this question systematically. First, identify the red flags. Age under 30 immediately suggests secondary cause. Female patient is classic for fibromuscular dysplasia. The abdominal brute is a pathognomonic clue for renovascular hypertension, and no family history argues against essential hypertension. Now recognize the test stem pattern. When you see young plus female plus hypertension plus brute, your brain should immediately think fibromuscular dysplasia. This combination appears frequently on board exams. The correct answer is fibromuscular dysplasia. If the question asks for the next step in diagnosis, order a computed tomography angiogram or magnetic resonance angiogram of the renal arteries. Make sure to review renovascular hypertension in First Aid and UWorld to see more examples of this pattern. Here is our next high-yield scenario. A 55-year-old man with poorly controlled hypertension presents with blood pressure of 220/130. He reports a severe headache and blurred vision. Fundoscopic exam shows papilledema and flame hemorrhages. What is the most appropriate initial management? This question is testing whether you can distinguish between hypertensive emergency and urgency. The management is completely different. This is a hypertensive emergency, and here is how to recognize it. The patient has end organ damage. Papilledema indicates hypertensive encephalopathy. Other emergencies include aortic dissection, acute heart failure, and acute kidney injury. The key question to ask yourself, is there target organ damage? If yes, it is an emergency. For the correct answer strategy, remember this. Emergency means intravenous medications. Admit to the intensive care unit and start intravenous antihypertensives such as nicardipine, labetalol, or nitroprusside. The goal is to reduce mean arterial pressure by no more than 25% in the first hour. Avoid oral medications in true emergencies. In contrast, hypertensive urgency has no end organ damage and can be managed with oral medications as an outpatient. Review this algorithm in your board prep materials. Medication selection questions are among the most commonly tested topics. Here are the first-line drug associations you must memorize. For diabetes or proteinuria, the answer is an ACE inhibitor or angiotensin receptor blocker. For heart failure, use an ACE inhibitor plus beta blocker plus diuretic. For African American patients without a compelling indication, start with a thiazide diuretic or calcium channel blocker. Here is the key test-taking tip. When a question gives you hypertension plus another condition, the correct answer is almost always the drug that treats both conditions. Boards frequently test coronary artery disease with hypertension. The answer is beta blocker. Migraine with hypertension? Also beta blocker. Review the compelling indications table in first aid to memorize all these associations. Let us work through another classic scenario. A 45-year-old man has blood pressure consistently above goal despite maximum doses of lisinopril, amlodipine, and hydrochlorothiazide. He is adherent to medications. Labs show potassium of 2.9 and bicarbonate of 32. What is the most appropriate next step? Notice the specific lab values in this question. They are not random. The test writers are giving you deliberate clues. Let us analyze this case step by step. First, define resistant hypertension. Blood pressure remains above goal despite 3 drugs including a diuretic at optimal doses. Before jumping to secondary causes, rule out pseudo-resistance, poor adherence, white coat effect, or inadequate dosing. This patient is adherent and on maximum doses, so we need to investigate further. Now spot the lab clue. Hypokalemia plus metabolic alkalosis equals primary aldosteronism until proven otherwise. This is the most common secondary cause of resistant hypertension. When you see low potassium plus high bicarbonate plus resistant blood pressure, think aldosterone excess. The correct answer is to order plasma aldosterone to renin ratio. A ratio greater than 30 with aldosterone greater than 15 suggests primary aldosteronism. Confirmatory testing and imaging follow. This workup sequence is heavily tested, so review it in UWorld and AMBOSS. Hypertension in pregnancy is another high-yield topic. Here is the question. A 32-year-old woman at 20 weeks gestation presents with blood pressure of 160/105 on 2 separate occasions. She has no proteinuria and no symptoms. Which medication is most appropriate for blood pressure control? This question tests 2 things: classification of hypertensive disorders in pregnancy and safe medication choices. Start with classification. Before 20 weeks equals chronic hypertension. After 20 weeks with proteinuria equals preeclampsia. After 20 weeks without proteinuria equals gestational hypertension. This patient has hypertension at 20 weeks, so this is right at the boundary. Since there is no proteinuria, this is gestational hypertension. Now know which drugs to avoid. ACE inhibitors and angiotensin receptor blockers are absolutely contraindicated in pregnancy due to fetal renal toxicity. This is a favorite wrong answer choice on board exams. If you see pregnancy plus ACE inhibitor as an answer, eliminate it immediately. The correct answer is labetalol, nifedipine extended release, or methyldopa. Labetalol is most commonly tested as first line. For severe hypertension in pregnancy, use intravenous labetalol or hydralazine. Review this in your obstetrics section. Let us summarize the key patterns you need to remember. Young patient plus hypertension equals search for secondary cause. Resistant hypertension plus low potassium equals primary aldosteronism. End organ damage equals emergency requiring intravenous therapy. And always identify the comorbidity to select the right drug. For your study resources, use UWorld Question Bank for practice questions and detailed explanations. First Aid for Step 2 has excellent quick review tables. AMBOSS provides in-depth pathophysiology if you need to strengthen your foundation. And UpToDate has the latest guidelines. Focus on the hypertension chapter in each resource for complete content mastery. That wraps up our hypertension management video. If you found this helpful, please like and subscribe to our channel for more high-yield board review content. We release new videos every week covering the most tested topics on your medical licensing exams. For personalized tutoring and residency application guidance, visit our expert tutors and residency advisors at roadmaptoresidency.com. We have helped hundreds of students match into their dream specialties, and we would love to help you too. Good luck on your exam, and remember, when you see those classic buzzwords, trust your preparation and pick the answer with confidence. See you in the next video.